Endometriosis can sometimes be diagnosed by ultrasound, but not in all cases. Endometriosis, when it forms a cyst in the ovary, such as an endometrioma, is very easy to pick up on a standard pelvic scan. But we often miss the subtle little cues about endometriosis in other regions unless we have a careful, targeted look at regions that we may not be looking at when we do a general pelvic ultrasound.
Well, endometriosis can be diagnosed usually with good imaging techniques such as ultrasound or MRI, but not always. Clearly, ultrasound and MRI are techniques that rely on the lesions being of sufficient volume to be able to be seen on such techniques.
Ultrasound probably lends itself to picking up endometriosis where there has been significant distortion to normal. Where it's in a very mild form, where the anatomy really hasn't changed appreciably, it'll be invisible on ultrasound. More than a half a centimetre to a centimetre to several centimetres, you might see that. But if you've got something that's literally a millimetre, you're not going to see that on an ultrasound.
Endometriosis in the more severe form, the complex form, however, can easily be seen on ultrasound, and it is particularly that we want to diagnose so that we can give the surgeon some warning about the degree of complexity that is expected during the surgery.
So the types of endometriosis that I think that can be reliably diagnosed when you undergo an ultrasound scan by someone who's trained in this area are deep endometriosis, cysts of the ovaries called endometriomas, and adenomyosis.
But we often miss the subtle little cues about endometriosis in other regions unless we have a careful, targeted look at regions that we may not be looking at when we do a general pelvic ultrasound. And some endometriosis occurs on the surface of the lining of the uterus and ovaries and organs of the pelvis, and endometriosis in those areas cannot be detected on ultrasound.
Deep infiltrating endometriosis ultrasound is a specialist ultrasound, and they have done training in recognising endometriosis, particularly endometriosis in hard-to-get areas.
Well, the concept of a deep endometriosis ultrasound scan, and often women that come to see me think that the scan's going to be a deeper scan, but it's exactly the same technology. So we're performing a transvaginal scan, but the difference is that we're actually looking at additional areas within the pelvis to try and improve our pickup rate for different types of endometriosis.
It is insufficient to just look at the uterus and the ovaries. What we have to do is we have to assess the whole pelvis. So a deep endometriosis ultrasound will not just look at the uterus and the ovaries, but it will include the bladder and it will include the pouch of Douglas behind the uterus.
So it's a more specialised and more time-consuming type of ultrasound, but it gives an enormous amount of information on the patient's likelihood of having endometriosis.
There have been several advances in imaging for endometriosis, but I must say one of the most positive things is the education and the awareness. So the more we can make our sonographers and our doctors aware of the signs for endometriosis, the more likely we are to diagnose it, even at a standard pelvic scan. If we can make people think about the red flags that may suggest that endometriosis is there, then they can do a more extensive scan or refer for a formal deep infiltrating endometriosis scan.
People have looked at how to improve the diagnosis of a thing called adenomyosis with ultrasound, which is related to endometriosis. It's a very similar project that's within the uterus, within the muscle of the uterus itself. And we've traditionally not been very reliable at picking that up, and there's a lot more interest in specific hallmarks of that disease that people are becoming more cognisant of, and I think that will improve our accuracy.
the development of a consensus statement that was published in 2016. And in that consensus statement, we agreed on the different types of endometriosis, but more importantly, agreed on the different anatomical locations for endometriosis. So what that means for patients is whether they have an ultrasound scan here in Sydney or in London or Rio de Janeiro, they end up having the same anatomical locations looked at and commented on. So at the end of that scan, that patient has a unified report with standard terms, standard definitions, standard nomenclature, and a report that I think is transferable between countries, so it makes sense for the person who then views that report, and more importantly, potentially has the advantage of improving the outcome for the women that are having those scans themselves.
So there are two types of imaging techniques that are commonly used now. There's, broadly speaking, the ultrasound techniques. And then on the other hand, there is the MRI, and that's that huge machine where patients are sort of rolled into a big, very noisy tunnel. The MRI has extreme good resolution, so the detail that we get is extremely high. One of the key disadvantages is that it is still images. It's like a snapshot and you don't get movement on that picture. And that's a very important, in my view, advantage of the ultrasound. So when the patient undergoes an internal scan, we can see things like what we call the sliding sign. We can see whether the uterus and the bowel slide against each other. If they don't, if they move as one, that's a clear sign that the bowel is stuck against the bowel wall. And that is something that is much harder to see, of course, on an MRI scan because it's a still image.
The advantage of ultrasound over MRI is it's cheaper, it's more easily available, and I would regard it as a first-line investigation. The advantages of ultrasound are that we can characterise the echotexture, so the appearances of the uterus on the ultrasound, whether there's a condition called adenomyosis, which is also a endometriosis of the uterus, which can also be seen at MRI.
The main advantage with MRI is that it is not an invasive procedure. There is no need to do an internal examination, which for patients with endometriosis can be painful. However, MRI is usually much less widely available, and most patients will be referred for an ultrasound.
MRI might be more suitable though for women who can't have an internal scan, such as adolescents or those who are not sexually active.
I usually take a little bit of a history from the patients before we start, and part of that is to give me an understanding of their disease, but part of it's also, I suppose, just to establish a relationship before you embark on the scan and make them more comfortable. I always make sure that they know that it's really not dissimilar to, in the way it's going to feel to them, to a pelvic ultrasound, and it's pretty exceptional for someone to come for a scan like this without having had multiple pelvic scans in the past.
When patients arrange to come in to have a deep endometriosis ultrasound scan, we tell them that there's no special preparation. Some units advocate the use of bowel prep, but we know that this is more a preference rather than a necessity. And then when it comes to allocating time, we allocate 30 to 40 minutes for the scan, although I think the scan on average probably takes 15 to 20 minutes. It depends on the extent of the disease when it comes to the patient that's having the ultrasound scan themselves. We get the patients to empty the bladder so their bladder's not full, so that the scan itself is comfortable. From a pain perspective, the actual scan itself I don't think is painful, but it can be uncomfortable. So we explain to the patients that it may well be uncomfortable, and obviously we tailor the scan according to the potential tenderness at the time of the scan itself.
And at the very end, when we look behind the uterus, that is a spot that is certainly more sensitive for people. So a retroverted uterus just describes a uterus where the top of the uterus angles back towards the spine. So if you think of the pelvis as sort of a basin, you have the uterus is in the middle of that structure, and you have the bladder at the front and the bowel at the back. And the bottom of the uterus is anchored, if you like, at the level of the cervix. So you have the body of the uterus at the top, the cervix at the bottom, and the cervix leads into the vagina. So the cervix is relatively stable, but the the body of the uterus can lean forwards or lean backwards. And a uterus that leans backwards is called a retroverted uterus, and a uterus that leans forwards is called an anteverted uterus. And if you sample a random group of people, 9 in 10 will have a uterus that leans forward and 1 in 10 will have a uterus that leans backwards.
Endometriosis, however, can be associated with a retroverted uterus in the sense that endometriosis can cause significant adhesions in the pouch of Douglas, which is the area behind the uterus, and it causes the bowel to stick to the uterus, and therefore the uterus gets pulled into this backwards position. And if that is the case, then that's obviously an association with deep infiltrating endometriosis. So I think it is important, if you have a retroverted uterus, that the ultrasound specialist may explain to you whether the uterus just sits in a normal retroverted position or whether the uterus is held in that position by adhesions, in which case it is very likely associated with endometriosis.
There's further research on superficial endometriosis and hints on ultrasound that we may have been missing that could help diagnose peritoneal deposits that up until this point have been very difficult to see.
More recent advances in relation to imaging for endometriosis, particularly for transvaginal ultrasound scan, is the introduction of a new technique, which is called Sonopodography, where it's possible to instill saline, put saline into the pouch of Douglas via the uterus via a very fine catheter, an intrauterine catheter. We install 10 to 20 mils of saline, which then passes through the fallopian tubes and sits in the pouch of Douglas. And this creates a standoff between the tip of the probe and the surrounding peritoneum of the pouch of Douglas. And so for the first time now, we can actually see small deposits of superficial endometriosis on the peritoneum of the pouch of Douglas. So I think that this represents potentially the final part of the jigsaw, where it's possible now, doing a detailed ultrasound scan, to not only see adenomyosis, endometriomas, which are cysts of the ovary relating to deep endometriosis, but I think with the introduction of sonopodography, it's now possible also to see superficial forms of endometriosis.